Thank you for joining us today for our webinar, Alerts and Alarms Management, 3 Steps for Mitigating Alert and Auditory Overload. My name is Kelly Elliott, and I am the Director of Marketing at Mobile Heartbeat and your moderator for today's event. At Mobile Heartbeat, we're passionate about communication and believe it's foundational to high-performing health systems. By the end of our time today, we hope you have a better understanding of how your data can provide valuable insights into managing alerts and alarms and the overall importance of governance when it comes to seeing the big picture. Our speakers today are Amy Clodfelter, AVP Nursing Informatics at HCA, Dr. Anna Baker-Garber, Chief Clinical Officer at Mobile Heartbeat, and Shell Pugh, Mobile Manager Application Support, also from Mobile Heartbeat. Before we get started, I have a few housekeeping items to go over. Everyone is in listen-only mode. We will have time for questions at the end of the event, but I do encourage you to enter your questions into the panel throughout the presentation. If we don't get time to answer all of your questions today, we will follow up via email. This webinar is being recorded and we will follow up after the event with a link to the replay. At the end of the event, a survey will pop up and we do appreciate your time and welcome your feedback. Lastly, for additional information like case studies, press releases, white papers, and more, please visit mobileheartbeat.com. Now, without further delay, let's get started. Dr. Garber, thank you for joining us.
Thank you, Kelly. Thanks to everybody who's on the line today. It's really great to have so many participants. And Amy, I want to thank you for joining us today. Amy has been working very closely at the HCA Healthcare Organization to bring a lot of value around mitigating alarm fatigue. And she's going to give us insight into her experience both with how to set up pathways and the impact of what happens when you pay attention to the 3 steps that we're going to go through today. And Shell is going to walk us through the data that's available and why that's so important. So we're going to hone in on the value of planning your alert pathways. We all know that alarm fatigue happens unavoidably, partly because there's just so much going on in the hospital, and we all have the desire to help the nurses particularly know about imminent changes in the patient's condition. However, we don't do a really great job of thinking about the whole ecosystem, and we sometimes don't pay attention to the important details of sending the alert that would lead to the alert being more effective and go off less often. So Amy's going to talk to us about the importance of that. Shell's going to walk us through the data and what's available to you. Amy's going to show us what HCA has done as a way of enhancing the data that views that you can get from Mobile Heartbeat. And then we're going to go over a case study about how to measure, optimize, and improve a sample of alerts. So we'll just jump right in. Making sure that the alert is targeted to the right person at the right time on the right event with the right action in mind is the key to an excellent and useful alert. And so when you look over here on the right screen, these are all the important questions to ask yourself. So Amy, you want to talk a little bit about why each of these items are on the list and how you think about what planning an alert pathway looks like at HCA?
Sure. Thank you, Dr. Garber, and good afternoon to everyone. So when we think about the rules of engagement for alert, they're very similar to those 5 rights of clinical decision support that many of you have heard about before, delivering the right information to the right person at the right time through the right pathway or the right, the right tools. So when you see here on the screen the what indicating the specific event, we really do a lot of stakeholder engagement, understanding the workflow and the policies that drive the workflow. And so we really want to go in, do observations, interviews. We're going to talk about data like we did before, like Dr. Garber mentioned on our case study of identifying where we have opportunities and then using an interdisciplinary team and really engaging our stakeholders to understand what we can do to help with those people, process, technologies, and making sure that we're thinking about the alert delivery, what they take action on, and what the expectation is for them closing the loop, which is what you see right there in the very last point.
So there's nothing simple about this, is there, Amy?
There is not, and each individual alert needs to be taken with its own individual workflow and its own thought process. So though the framework and the approach should be repeatable and the signal delivery needs to be reliable for your caregivers and your clinicians, because we don't want to introduce any risk or make any safety concerns, you really need to be thoughtful about every alert that is requested and make sure it's not duplicative, it's not false, there's not a lot of non-actionable alerts that you're starting to pile on, because again, as Dr. Garber mentioned, alarm fatigue is real, and so we're trying to make sure that it's meaningful and actionable to our caregivers. So you have to think about all of them individually. It's not a one-size-fits-all for your organization, even though you can take the approach in a similar method.
So I like the fact that you're driving home the message about an actionable alert. And so talk a little bit about why informational alerts seem helpful on the surface, but aren't so, but actually are a detriment to the nursing mindset.
Right. So sometimes we think, there's information that's nice to have, but you have to think about it in terms of what's the urgency, what's the priority, and what am I going to do with it right there in the moment. And that's where you have to think about what's the correct delivery mode for them, what's the right way that you're delivering that information. And so for Mobile Heartbeat being your wireless delivery tool that's mobile and right there in the heat of the moment, that's when I want to get information that I need to know right then at the patient's bedside, for example. If it's information that could be informational in the EHR and I'll see it at the moment in time that I don't really need it right there, then maybe it's better as just a notification on a status board. And trying to make things duplicative for the sake of I might miss it somewhere else, that's what's impounding that information overload. And, if they're not needing to take action on it, then you're asking the nurse to prioritize more and more information on the same device, and that's what either desensitizes them or takes up more time than they have, and then that's taking them away from other tasks they need to be doing with their patients, and that all contributes to what we've known now in the industry as alarm fatigue. So you really want the action on that device to be actionable because it's a priority and it's an urgency in that immediate time frame.
So I really like that you've emphasized the action and understanding what needs to be done in the immediate time frame. And the other, and so that's one of the big differentiators about why sending an actionable alert is important as opposed to informational. Typically, an informational alert doesn't have, kind of by definition, doesn't have an action that goes with it. The other component is who is supposed to take the action. So I know we've all fallen into the trap of the more people that know and come to take action seems like a good idea, but help us understand why actually that's also detrimental.
Yes, well then I don't know if you took care of it or I'm supposed to take care of it, right? In basic terms, if everyone's getting the message and only one person's expected to do something about it, how do I then know that it's me or it's you? And again, going back to the sense of urgency and priority, then I've got to communicate to others, which is an additional alert or signal, if you will, to someone else to say, did you get that? Did I do that? So again, you want to be targeted and then allow for escalation protocols if the system allows so that it's automated. Did you get it? Okay, I've got it. I'm going to go stop the signal. And then if I am not able to answer it, it automatically escalates to someone else. So that's where you want to take advantage of those automations and those escalations in your system when possible so that I know by the time it gets to me that someone else probably didn't have an opportunity, so I really need to go stop what I'm doing, depending on the urgency, and address this, or I know that if I can't get to it, someone else is in that pathway and they're going to go get it.
So it really brings clarity when you single out who is supposed to take action in what sequence. So all of these things, though, what's the signal setting off? Who's it going to? What's the action they need to take? And then what do you do if that first person can't get there? Those are all the components of the workflow that we had on that last slide. And that amount of detail needs to be worked out before you do any kind of implementation. And one of the things that you talked about, Amy, was, if this happens, the path goes one way, and if it doesn't happen, if somebody doesn't answer, what's the next thing that happened? And so you're going to talk about that in your case study. So I just want to drive home the point that a lot of thought has to be given into each of these questions, and it needs to be spelled out in detail, and before any kind of alert is then programmed from the signal generator, whether it's a bed alarm or a telemetry alert or an SpO2 alert or a sepsis alert, and then who's going to take care of it and what action they're supposed to take. So once you have that all figured out, you want to be able to take a look at your data and understand what your data is telling us. So Shel, will you walk us through what's available in Mobile Heartbeat and how people access it?
Yes, definitely. So I'll speak to some of the reporting that we expose via the Mobile Heartbeat admin portal. So anytime a user receives an alert in MHCure, that alert is created as a record in your Mobile Heartbeat environment that you can expose via the admin reports. I think many of you on this call are familiar with the admin reporting console. I'm going to highlight some of the reports that are relevant to extracting and looking at this data. Go to the next one. While we talk about use the word alert, I just want to kind of level set the ways that appears in the app. So the first way, right, alerts are the alerts that you see in the alerts tab, kind of the bell at the bottom of the dashboard, right? Most of our integration partners and most of the third-party systems that send us alerts using WCTP. It's a kind of communication protocol. That's Hillrom, ASCOM are the two big ones, but most alerts are delivered to the Mobile Heartbeat system using WCTP. That shows up in the alerts tab at the bottom. In addition, some third parties send us alerts via phone calls, and if you hit next, that should show up. This would be, for example, Roland, and Kelly, if you could hit next. This is Roland, for example, one of our third-party systems that send us alerts via phone calls, right? These use SIP technology, so they're delivered to the mobile user, and they show up in the phone calls tab. So there's kind of alerts are used to talk about both these phone call alerts that Roland sends us, for example, and then these WCTP alerts. In the admin reporting console, there are a number of reports that you can use to extract this data. This is where you can go to the next slide. There are 6 reports that I've highlighted. There are 2 buckets of reports that we have. There's the analytics report, so this is more holistic, kind of show the volume of alerts received and sent over a set period of time. And then we have the audit reports that'll let you look at that data at a more user level, so you can see the individual content that users are receiving. So the first report I'll show you is this WCTP events by location. This is one that you can look at alert data over a segment of time. You can see in this report that you can see the volume of alerts received by users in particular units in a hospital over a given day. You can see, for example, that this 2 North unit on the 17th received 102 WCTP alerts from Hillrom. This is more kind of holistic, right? You can see the volume or the volume of alerts that users receive, broken down by location and date. The next report is the WCTP messages or the call history report. Now, talking about the phone calls, right? This is one of the mechanisms by which alerts are delivered. Roland, for example, these alerts you can look at using the call history report. And if you highlight one of these examples, right, this is what the data looks like. If you hit next, I'll highlight one of these rows in particular, right? This is what the data looks like. You can see some of the relevant fields here. Obviously, the date and time, the recipient unit, so where they were when they received it, the recipient username and role. And then most important are the two columns on the right. The second to last column, the other party call ID, this is the nature or the type of alert. So you can see Pat, for example, received a water alert. The patient was requesting water. Abby received a pain alert. So the patient was hit the kind of bedside button requesting assistance. You can see this is the type of alert. These typically follow the format of the room and the bed in which the patient was. So this is how it displays in the mobile heartbeat system. And then the other party ID is the phone number that from which the alert was generated. The last report I'll highlight is the WCTP messages received. And this is the one where alerts kind of generated via WCTP, this WCTP protocol. They will appear in this report, so different delivery mechanism. A lot of the data looks the same or kind of the same main content. If you click next, I'll highlight one of these specific examples. Again, you can see the recipient hospital and the unit, so the location they were, the source, so these were Hill-Rom alerts. The alert title is used to tell the type of alert, so this is a bed exit, the patient got out of the bed, the date and time, and then the payload is the actual content of the alert. Sometimes it's just the type of alert, other times there's more data, and then the recipient username and name, and then the priority of the alert. So these bed exit alerts have been configured to be urgent. Often that means they'll play a particular tone and might even override the phone or the volume settings on the phone because they need to be actioned immediately. These are just three of the reports that you can use to look at some of this alerting data that users receive via mobile heartbeat. I'll pass it on to Amy to discuss some of the data they've collected at HCA.
So Sheldon, just before we move on to Amy, they have to do something with that data, right? There's no analysis available in the admin reports. It's really an extraction of information, right?
Yeah, correct.
So walk through the steps that go from this to what Amy's about to show us.
Yeah, so this data again is presented in the admin console. There's always the option to export it as a CSV or Excel file. That requires some manual manipulation. As Amy will show, this is some of the data that they've pulled through their data warehouse, HCA's data warehouse, into Tableau, into another data visualization tool. So it takes this data, this raw data that MHCure collects, and spits it out in a more user-friendly and say usable format that allows you to look at some of this performance data.
So customers of Mobile Heartbeat have the option of saving the data in their own data warehouse, and they can also come to these admin reports, take a look, pull those files into Excel or whatever, and then manipulate it after that.
Right.
Okay. So now let's go. This is like doing a cooking show, right? Okay. Now we're going to pull the turkey already baked out of the oven and it has a beautiful brown glaze on it. And Amy, tell us how you got it here and what are we looking at?
Great, yeah. And I would say there's value to both of those, right? I pull reports out of the console for specific needs to filter and sort, and then there's value to having your own analytics tool here. And so as Shell pointed out, you know, informatics and data folks have to understand the differences when they're looking at these between the different protocols, so the WCTPs and the SIPs, and sometimes those semantics throw off our business folks because alerts and alarms get used kind of interchangeably, and some people get hooked on those. So for now, we're just going to think about these as all wireless signals, so no matter what you see titled on here, I'll kind of walk you through this. But here you see a heat map, and these are the WCTP alerts because we have multiple systems in the enterprise that I'm looking at. And here you can see across the top, I've got a nurse call system for call lights. Raven is a middleware that we use, and then we have a telemetry system. And so these all come through like an alert actually on the mobile heartbeat system. And we've taken these, we've put them into an analytics report, and I can look at the landscape now across multiple units, across multiple systems, and this helps us not only identify initial opportunities. As you can see here, I've got a dark blue, which is the highest volume across these systems, so I can think, well, is that normal? Is that not normal? Is that an area of opportunity? And it allows me to say I can go maybe look and do some observations and end users to see if that is a potential bad actor. And then I can go back and look at this data and then measure and see if I've made any, monitor and measure if I made any changes when I do have an intervention. So it really helps you start identifying where you could have a problem, and then it helps you with your continuous quality improvement projects. And so it's very valuable for the whole maturity of your alarm management program. And again, it's really about patient safety, risk to the system, and so, you know, very valuable to have this and looking at it.
I remember when we first looked at this data, it was an eye-opening experience to think about how many alerts were coming through just the nurse call system alone, let alone telemetry or other kinds of alerts. And you know, when you start to divide the math, you know, the numbers of alerts by the numbers of nurses, you quickly realize how inundated nurses are and how much they're interrupted. And what a cognitive burden that creates. It just, you know, like having your kid pester you every 30 seconds for something, or your dog pester you, you know, yeah, then you got to get back to what you were doing. And so the alerts then start to have that I'm being pestered feeling to them, as opposed to having value. So
yeah,
go ahead.
And if you think about it, I mean, this is just one piece of the pie, right? This isn't the whole landscape of all the functionality, phone calls, or the whole environment of care that they're operating in. But there is so much power to seeing this on a screen for people. We talk about it, and when you go into a hospital, you even hear it as a leader or you know, an operator. But when you really put a number in front of somebody, it has power. It has a lot of power to open your eyes, like you said, Dr. Garber.
Great. So, so you've got more than one way of visualizing the data. Let's go look at the next one.
Yeah, go to the next slide. So here is the other side of the nurse calls. So that was one. This is, you know, the ones that come across as phone calls, as Shell was going to. Yeah, the next slide's good.
Going the wrong way.
Oh, yep. There you go. So this is a different view. So the other one looked at numerous systems, kind of as a comparative, and this is looking at a single system, so a nurse call system across one facility. So this is helping me look unit by unit to see at individual call types, patterns and behaviors. So again, we can't make any assumptions here about what's good or bad initially, but, you know, having organizational knowledge and maybe kind of understanding already the workflow, you could. But for me, looking at this, I'm saying, oh man, look at that bed exit. So when a patient is a fall risk, they have a bed exit alarm, and when they get out of bed unassisted or attempting, you know, that goes off, and that generates these wireless alerts in mobile heartbeat. Well, one of these top units, it's got a whole lot of them. And then the one in the middle, it doesn't have as much. So is that a process? Is that a people? Is there something in the technology? I don't know, right? But that's a place to start, especially if your nurses are saying, man, I got a lot of noise. I got so much noise, I'm silencing my phone. I can't get to the other alarms. So this is where having the data lets you know where to start and evaluate. Because we all are super busy. There's a lot of, you know, there's a lot of opportunity, but at least then I can go do some observations and look at this particular event and understand and ask them, is this a problem for you? So That's how I use this data here. And again, once you do have an intervention, then you can come back and use the same data to measure and monitor ongoing that it's still being, that it's effective and being adhered to.
Right. So, you know, nursing leaders are very passionate about having everybody come running when the bed exit alarm comes off, right? Because it falls a never event, and we certainly don't want our patients incurring harm. And while that sentiment is very well intended, it's not particularly effective. So, Amy, do you want to start walking us through the components to that are important for changing the mindset of the nursing leaders and the culture of that process? And then you did a beautiful study for your doctoral program, and we'd love to have you walk through the interventions, how you assessed it, and what the interventions were. So let's start with the how to help see the big picture and how you engaged leadership to buy into the change.
Yeah, so the term governance here, I'm going to use the term, you know, change management. So it takes an interdisciplinary team, right, to get the buy-in. I can't just go in and say, this is what's right, this is what your workflow should be, this is what your policy should be. So we really looked at the data, worked with the end users, the nursing staff, the nursing leaders to really understand, what do you think is the most impactful? So after we went in and did an assessment, outlined what the workflow was, saw where the non-standard practices were, and understood what the system was capable of, which I'll talk a little bit about that in a minute. But you've got to understand your systems as well. Then when you can kind of draft out what a future state, ideal state workflow could be, that's when you start having the discussion to say, okay, nurses, what would help you? Because they are the ones that are accountable for using the system. So if it's not useful for them and they're not going to respond to the new alerts or the new communication pathways, then it's never going to sustain and be meaningful. You're still going to have burden to everyone else and all the other staff who are getting those alerts or who's taking up the slack, right, for responding to the patient. So that's a big aspect of it, about getting that buy-in. I think that it's a continuous quality improvement, though. We've got a lot of staff turnover today. So you have to just make sure that your leaders are there to ensure that they appreciate what it takes for ongoing alarm management in this space. And then again, you have to monitor other data points that may be outside of the mobile heartbeat data to make sure that there's no unintended consequences that you're introducing into the system, like increasing falls when you're doing, you know, a process improvement project like this. So we can kind of go through that. I have a few other slides that we can talk about some of the experience.
All right, let's get to it. Let's do it. So your study really represented sorry, Kelly, just go back a half a step at one slide. So you just talked about all these important components, right? And these are the steps that you went through as part of your project to optimize and improve the bed exit alarms, right? So is there anything more you want to add to the things that are on this slide?
No, I don't think so. This is pretty comprehensive.
Right. So, okay. So as you were embarked on your study, why don't you walk us through what you found was the state of affairs before you got started?
Yeah, so just some background, you know, in our organization, we've got 90,000 nurses. Coincidentally, we have over 90,000 phones in circulation. And, you know, we had events where people were silencing phones. I mean, we've got a lot of noise. And so, you know, adding more and more technologies, we have to be cognizant of the governance, as we said earlier, around what we are delivering. And so when we looked at the data and we knew that one particular place was saying, hey, we want some help, we looked at the data and saw that, you know, the bed exit calls were accounting for about 50%, give or take, on individual units in the med-surg areas. So what you see here, this is just 1 month. And for those of you who are unfamiliar with all the different types of wireless alerts that can come to the phone from a nurse call system, there's the bed exits, there's normal calls, get me up to the toilet, water, etc. And some of them have different priorities, like a normal or urgent. And the difference there is who they go to in terms of escalation. So some of them can go to a patient care tech, like getting water. Some can be programmed to go to a nurse first on the phone, like pain. And then some of them, if they're urgent, can go to everybody. And so this was a really interesting learning situation where, you know, they treated code blue the same way as bed exits. And so when we went and implemented smartphones in a place where we didn't have wireless integrations before, you know, at first you just heard it in the environment, dome lights, noise, and people responded that were in close proximity. And then when you added on all these wireless smartphones, it started just going in the environment with tones and lights, but everybody was getting it on all their phones all the time for every single patient, regardless of where they were in the unit or not. So it was just overlaying new technology, kind of over like old pathways, if you will. So if you want to go to the next slide. So we went and we did this, we collected all that information by doing observations and interviews. So you can't assume that you're the expert. We talked to end users, we talked to product engineers, because again, you got to really understand your systems, because the triggering system is just as important to understand as where the signals are being received and how you can create those pathways. So we talked to a lot of subject matter experts, including the vendor, the local informatics teams, to understand the culture, the policy, the workflow, how that came to be. And then when we talked to the different units, because, you know, you make a change on one unit, but staff float in between, you know, we wanted to make sure that that everyone was going to have understand the processes on every unit, because nursing staff floats. So there was conflict between staff, no defined, you know, supporting policy. So we understood that there was a lot of consistent inconsistencies, if you will. So for the sake of time, if you want to go to the next slide. So again, you know, this particular call light for bed exits was going to everyone on the unit for every single patient for a couple of reasons. One, again, we had implemented a wireless phone kind of over an old workflow, and that system treated all urgent signals the same. Everybody had to get them. And then also, as Dr. Garber mentioned earlier in this, is, you know, the nursing leaders believed that was the safer way to do things. If everybody gets it, then somebody's more likely to respond. And that's not really true, because I might assume you're going to respond, or I might say, it's not my patient, so it's your responsibility. It creates conflict in the cognitive understanding and the accountability and the responsibility. So we were trying to kind of dispel the myth that just because everybody gets it, it makes it safer. And you know, that's not really that well documented in the literature for this particular use case. So we had to make some assumptions there. But, you know, the nursing staff were the ones that made this decision. And so that is, again, what helped us get through this journey, is because they said, yes, we will be more accountable. Yes, we will be more intentional. This is what we want. There was a day when we knew how to respond based on other signals in the environment. So we changed it. We changed this, worked with the vendor to create, if you want to go to the next slide, to create a targeted escalation path that went to the care tech, the nurse, and the charge nurse that were assigned to that patient. Those were the only ones getting the wireless alert specifically for the bed exit event. So again, we had to work with them because their system wasn't originally designed to manage that for certain urgent calls. So it did take some testing and programming, social programming on their part and our part. But by doing so, we reduced the wireless alerts to the rest of the people, so non-actionable alerts, nuisance alerts, by 75%. And we also, if you want to go to the next slide, when we did that, we monitored response times, we monitored falls for several months after that. So again, the unintended consequences, as I spoke about earlier, we monitored those because we wanted to make sure we didn't introduce any risk or unsafe events into the system, and we did not. So, you know, we standardized some workflows, and I kind of skipped over that, but we educated people on standard practices like making assignments timely, how to use the devices, both the hardware in the room and the phone a little better, and then we changed the escalation paths. So those were all the interventions we did for this, and that did show, again, a reduction in wireless calls that were nuisance calls before because people weren't even around to answer them, and then no change in response times, and no increase in falls. And then the final slide on this, which is my favorite part of the whole project, is that we interviewed the staff for several weeks after that, and you can see here, we definitely impacted noise, and you can see here they became more intentional. What's interesting is that we never introduced this project as a solution for alarm fatigue. We just said that we were trying to reduce nuisance alerts. And so the fact that they used that term so frequently in their quotes back to us lets you know that the bedside nurses are quite aware of this as a problem in the industry, and that they know what the name of it is. So it was really meaningful that we were able to take just one alert, one call type, and one system, and create some change. So it was very, very fulfilling to do that. But it took data to do that, and that is very important.
So congratulations. Those results are nothing short of spectacular. And you know, I want to go through and kind of summarize the steps that you took, because I think they're worth reiterating. But before I do that, what did you do with the dome lights and the auditory piece? Did they all, how did those get managed in the pathway?
Yeah, so in previous work as an organization, we had already created some standards around the dome lights and tones from the phone. So we have set expectations that, you know, lights for falls are a certain color and they behave a certain way. We also have the tones mapped to standard event types, like all the patient calls that are routine are a certain color, like white. The tones are for routine ones are a certain tone. Urgent tones like code blue have a certain tone, and then a bed exit has a different tone. So we had done that exercise before. There was a little standardization that we had to do on some of the older units just because of the differences in the design of them with newer units. But that work had already been done, and so the nurses, you know, that is the best thing, is that the signals, there's already signals there to say there's a problem right here. I can hear it in the environment, and they also have a no pass zone, which had not been hardwired. So we took the time to bring that back to life, dust that off, and make sure everybody remembered that if you're a clinician or not a clinician, you are still accountable if an alarm or noise is coming from the room to go in, check on the patient, and then go call somebody else for help. So there was policy and workflow that went into that. It was not all just about changing configurations in the system.
So even the work with the dome lights and the sounds illustrate the points that we're trying to make. Specific signals have a specific meaning that specific people are supposed to do a specific behavior with, right? And so whether it's a flashing light as an alarm, or whether it's coming across as a phone call or a WCTP message, all those components still apply. The other thing I heard you say, Amy, is that 3/4 of this work is really about the process, getting engagement, changing mindsets, having the conversation where everybody's on board, the willingness to try something new. All of that is change management, political, if you will, engagement work that needs to be done, and getting commitment to follow through on those changes. And then there's the technical component of making the system match the specifics in the workflow, and making sure that they represent each step specifically and people know what to do with each of those steps. And then we've got to measure before and after to see what the impact was. So I can think of very few interventions in the healthcare world where you can make, 3/4 or something bad go away. So congratulations to you. I know it took a big team of people to do that, and your leadership and insight was really valuable.
Thank you. Thank you.
So I think this is a great place to conclude. I think that Amy's study is a good example of the points that we were trying to illustrate today, and I would be happy to entertain questions. I see one coming in from the chat here from Ryan. How does clinician usability of the data fit into the question of getting it right? So how does the clinician usability of the data fit into the question of getting it right? So Ryan, I'm trying to understand what you mean by clinical usability of the data. Do you mean how easy the data is to interpret, or the clinician's experience? Help me understand what you mean by clinician usability of the data. Can we take him off mute so he can, or welcome to chat, type in the answer, the response.
I think it's the first part, Anna Baker, how the clinicians use the data.
Okay, so Amy,
Yeah.
do you want to talk a little bit more about how you help the clinicians understand the data you were seeing?
Yes, so I think about this as in terms of like an audit and feedback mechanism. So as we mentioned earlier, when you put something in front of people, it really makes their eyes open. And so what I did as part of that work is pulled down the data, showed them this is really how many alerts you're getting, and both to the nursing leaders and to the nursing staff. And so they knew they were getting a lot of alerts. When I showed them that, like just a plain old graph like I showed you, they were like, wow, okay, we hear you. This made our eyes open. And so then during the implementation, pulling down those daily reports, showing them weekly reports about look what you've done. So by being accountable for the interventions and following suit with what we've laid out, that and being able to make such a reduction, that helps drive people to the right process. So, I know lots of hospital leaders do that, where you have boards of like what you're doing, moving the target. But that's really important. The data is really important to helping your nurses feel engaged. And so talking them through it, that was part of the change management too, but it's part of ongoing. And especially when you don't want to have you don't really know what good looks like yet, it's okay to like set a target that says, let's try to make some sort of meaningful improvement and then make an improvement from there. So that's how I use the data to get their engagement. And
so
then let them know.
The other piece that you did, which you haven't talked about explicitly, was there must have been some translation between WCTP and SIP and what that means to the clinicians, right? It comes out in techies out of Mobile Heartbeat, and then you've got to translate that into what it means to them. So you want to say a few words about that before we conclude here?
Yeah, I mean, I don't know that we have our end users, our clinicians going in and pulling these reports. So I find that more of the role of our product teams or informaticians. So when I pull those out, I don't typically, when I make those displays, I would not be, I wouldn't be putting those types of terminologies on the screen.
Right.
So I
label
try
it
to
in a way
change.
Sorry.
Yeah, yeah. I try to put it in layman's terms as much as possible.
Okay. Ryan, I hope that answered your question. Okay, so Kelly, you got the last slide up, so I'm thinking that means we're at the end of our time together.
We are at the end of time. I did want to say that in the follow-up email to this event, I will be including a link to the white paper that was co-authored by both you and Amy Clodfelter. So please look out for that. There's no form. It's a direct link to the paper. And if anybody would like additional information on this subject, feel free to join us at our complimentary user conference, which is taking place in October here in Boston. We would look forward to seeing everyone there. We'll be doing a deeper dive into this subject and others. And yes, I thank everyone for their attendance today. Thank you, both Amy and Shell and Anna Baker, Dr. Anna Baker.
Thank you, everybody, for attending, and we hope to see you in Boston.